Hi, good morning, and thank you for having me. Thanks for the introduction. I'm actually at Epilepsy Foundation event this morning as well, so I'm presenting from here, but so grateful to be invited for this talk today to celebrate the 10th year anniversary of Cure. I'm going to have some slides to share if you wanted to let me. Um, can you see my slides?
Yes.
Okay. Just for some background, so my background is I'm a associate professor in neurosciences at UC San Diego. I work at Rady Children's Hospital, running the Precision Therapeutics and Neurointerventional Program for Batten's disease, a rare neurodegenerative disorder. And I'm part of the Rady Children's Institute for Genomic Medicine and n-Lorem Foundation and CERN. So I wanted to talk today about the process of genetic diagnosis to rare disease, precision therapeutics, and hopefully this continues to be the future. Um, and I know that your mission line was a community for the complex, undiagnosed, rare, and extraordinary. And this is really, it's challenging when you're first coming up with the new symptoms and going through the process of getting a diagnosis, especially when it's rare. A rare disorder is very uniquely different from more common diseases, and so we can talk about some of that and how that experience is, and hopefully um, bringing some community together. That families foundations are often what brings forward new change in therapeutics and science. And so I really appreciate your mission. Oftentimes, when we first have a child coming in, the experience of a new neurologic symptom or concerning child in our clinic is oftentimes a first time seizure or developmental delay, developmental regression, where you had skills that you previously loss of previous skills or a delay in the acquisition of skills. And so that can come along with many, many other symptoms, especially in rare genetic diseases, where it can manifest with other system involvement, whether pulmonologic, gastrointestinal, cardiac. And so this diagnostic odyssey can take very long. And there's tiers of testing, including genetic. Oftentimes I'll hear that everything came back negative, but there's many layers of that kind of diagnostic testing um, that can happen and also should be covered by insurance, although isn't always. And so concurrent symptomatic management and medical care is what we start with when we're first coming up with a diagnosis, initially just stabilizing symptoms, and making sure that we are safe and what can we do in this current moment. And as we are taking care of our kids in that sense, then we come across what's the etiology? Why is this happening? And what can we do about this? And the intervention, what is the current available treatments? And the search for treatment opportunities can become quite urgent, as many of you I'm sure have experienced. As many of times the diagnostic workup includes a video EEG like this, where you don't know what's happening in your child the first time they're unresponsive or um, having abnormal movements. This is an example of a video EEG monitoring unit where you have electrodes placed on your head, as some of you may have experienced with your own children, and where we're recording seizures as they happen live and looking at brain activity. These are different electrodes monitoring seizures, and this is a right-sided seizure that manifested with left head deviation followed by generalized tonic-clonic activity. And when you first see something like this, it's so frightening and out of the blue for your own child who may have been previously healthy. Um, and so that just will drive you to see what can we do? What can we do to help? Rare diseases, the Rare Disease Act of 2002 defines rare disease as a condition affecting less than 200,000 in the world, and estimated there's over 10,000 diseases and conditions that would cumulatively affect 25 to 30 million people. And so it really needs to be prioritized as a significant public health concern. because not only for the individual kids that need help, but because there's so much significant morbidity and mortality, and earlier diagnosis will lead to better care and better treatment opportunities. The diagnostic odyssey is specifically unique in rare disease because of the fact that there's so few other people in the world. You may be the only person that you know, and now with at least internet, there's access. But before internet, you can imagine that there's very isolating to not know anybody else. Um, and oftentimes there's very limited known science about the disease, the individual disease, and and limited resource allocation, whether that's scientific inquiry or financial resources. And even along there's within the same rare disease, there's so much genotype, phenotype heterogeneity. So someone with the same variant may have very, very different disease manifestations where there's some overlap, but not always. And so even on the day to day, what that experience is like, even if you find somebody who is having has the same diagnosis, the experience can be different, and how that treatment unfolds for your child can be different. And this is also a challenge. When we talk about nano-rare and the spectrum of rarity, it goes, there's progressive rarity to the extreme, where nano-rare, described by n-Lorem Foundation, and is less than 1 in 30 in the world, 1 to 30 in the world. And you can imagine that as you get rarer and rarer, that challenge with the diagnosis and the treatment potentials for development are more complex. There's a number of factors that come into play. When things are more common, there's often more multifactorial etiologies. The rarer you get, if genetic, is often genetic, a genetic component in childhood with childhood neurological disorders that present early. So the extremely rare genetic mutations, going from genomic sequencing to targeted cell and gene-based therapeutics, because they are often single gene mutations and monogenic, that offers a potential treatment opportunity. Pathophysiologically, it makes sense that you would try to approach that. Most of these mutations are de novo and not inherited from parents or familial. Many of them are channelopathies or mediate some sort of neuronal or cell signaling pathway that mediates cell communication. And so this is an opportunity for targeted genetic intervention based on the underlying pathophysiology of the genetic variant in discussion. When you're talking about precision therapeutics for genetic disease, really understanding the underlying molecular pathology is really important because of the genotype-phenotype correlations. And as we discussed, the heterogeneity is broad, even within this genetic variant. And so natural history becomes really important in understanding it for within the rare disease community, as well as individualized. And here there is opportunity for targeted precision therapeutics in some forms, especially monogenic childhood epilepsy, where not existing novel technologies can be applied theoretically to the extremely rare diseases. And because these things are in play or have already been approved by FDA for other although rare, but less rare diseases, with already disease modifying effect as approved by FDA. And these can come in the sense of antisense oligonucleotide ASOs with RNA editing. And so there's a huge unmet need. Most nano-rare or very rare patients are never diagnosed. There are very likely more who are undiagnosed worldwide. And the average time to diagnosis, according to the Undiagnosed Disease Network, UDN, is 8 years. And so mutation-driven drug discovery and development provides an opportunity for treatment in these cases where the standard commercial model can't work because there is not enough, it's not feasible to expect industry to develop and create these drugs when there's so few that you could apply for, at least as we know of. Again, it comes back to there's more that are out there that are undiagnosed, I'm sure, but at this time, with these really rare patients, those commercial effort isn't possible. And that's where multiple players, multiple partners and groups are very important in bringing these kind of things forward for the rare disease community, including nonprofit companies and nonprofit foundations like n-Lorem Foundation in collaboration with other funding mechanisms, whether foundational or through CERM or et cetera, and bringing forward the same opportunities for our children who have the most rarest variants. They should also have access. And looking at n-Lorem Foundation, which is creating drugs, really at no cost for these really rare conditions. Their first 173 applications, according to date, and significant range in time from symptom onset to diagnosis. There, in this 173 applications, it was up to 36 years, 1% it took for them to get diagnosed, and on the shorter end, 1 month, with average of 4 years. And that's I think that this probably is a skewed representation of how long it actually takes, because many of these individuals are very aware of the opportunities for therapeutics like this with ASOs, and so may have been earlier to diagnose, knowing that what may be out there. And so there is a way forward with patients with extremely rare mutations. Can we create this kind of technology and bring it forward? And it is happening through n-Lorem and through others, really leading the cause to create this opportunity for all the children who have such similar monogenic conditions, presenting with such severe developmental delay, seizures, GI symptoms, pulmonologic symptoms, often with frequent hospitalizations, many seizure medications many medications in general that they have gone through, and many hospitalizations can lead to morbidity, mortality. And so this technology that's already available should be available for others, like kids with very rare diseases. In terms of ASO technology, it's a rapid and efficient technology. This slide borrowed from n-Lorem, in which it is versatile. There's multiple post-binding mechanisms, multiple routes of administration, and multiple organs. It's really validated and understood. There's a long history of ASOs. It's N of one or N of few is more of a newer approach, but the ASO technology as a platform has already existed for years. And it is cost effective, it's rapid and inexpensive, and it has long-lasting effects with a low manufacturing cost of goods. And so quite scalable, and that's why it makes sense to approach this and see the applications to multiple diseases. And we talked about there is extensive ASO history. It's not a new technology, but in applications here to rare diseases and fewer cases, fewer N of one cases or N of few cases. The potency and therapeutic index of ASOs in the organs. There's different organ systems that can be applicable. Most of them are going to be the central nervous system, the CNS, which will require intrathecal delivery into the cerebral spinal fluid by lumbar puncture. Other diseases, depending on the disease and the underlying pathology, may require delivery into other organs, liver, lung, kidney, or eye, and delivery in different methods appropriate to that underlying disease. And so the process for discovery and development of an optimal RNase H1 ASO for the central nervous system at n-Lorem includes a process of screening ASO design and primary ASO screen to look at optimal sites, and then a dose response evaluation, and then progressively getting safety and which ASOs might have less immunologic effect in a toxic way. And so going through the pathway of identifying the best ASO candidate for potential clinical trial use is kind of a pathway that's standardized across diseases. And when you're designing the ASO and it's based on the genetic variant, and it's tailored very specifically to the individual, the same needs to be in play for clinical trial design because of the genotype phenotype heterogeneity and these rare diseases. And so when we're looking at the how the symptoms are presenting in a child, what is the significant symptoms of concern that would be a key outcome measure to look for safety and efficacy of such investigational therapies. This is important to know as a run-in before any sort of trial, to know if there's is there a minimal change? Is there a change that is seen based on intervention with an ASO? And so we need to have a baseline history to see that. And it can be quite challenging in rare diseases because of limited data, but along those lines, individual history will be very important. And so at n-Lorem, the applications are initially assessed for feasibility, and once accepted, there is a process of the ASO discovery and optimization, as we previously noted, and then the preclinical development. That IND also then is in preparation with the FDA before we get to clinical delivery for trial implementation. This is the first patient at n-Lorem 0001 who has a toxic gain of function, loss of function mutation in SCN2A, which is a sodium channelopathy. And so just as a case, this patient was hospitalized initially at 1 month of age, and his first seizure presented with infantile spasms at 8 months of age and was referred for hospice care by age 2, with almost 30 hospitalizations early in life. And currently his phenotype, he's 15 years old. He has intractable seizures and severe movement disorders with developmental delay, severe, where he's nonverbal and non-ambulatory at baseline with significant gastrointestinal issues. And because his mutation is in a sodium channel, this NAV 1.2 missense mutation, it is very important in action potential propagation and nerve communication. And so it can manifest, as you can imagine, in many different ways neurologically. And so for him, what's the process in going to this type of treatment? It's, of course, you need to have the genetic testing, and that's not always available for this situation. They did sequencing supported by the family who got the mutation characterized through collaborators, and then had the ASO developed through n-Lorem Foundation and is currently under ASO treatment. Just kind of going back, if we don't have a genetic variant and it's suspected and the diagnostic, I like to just keep reiterating in this situation that sometimes the opportunity for treatment informs change, and hopefully these kind of therapeutics that come down the pipeline continue to bring forward more diagnosis, because as a practicing physician, I always have trouble with the genetic testing being approved by insurance. It shouldn't be the case. And more it is becoming more readily available. But again, the diagnosis is extremely important, even to allow if this is a possibility. And so we began his clinical trial as a personalized antisense oligonucleotide for SCN2A. And this is a single participant clinical trial with ASO that was based directly on his mutation just for him. And he is currently in clinical trial. And so there's some media coverage because this is not more in a novel approach to individualized medicine. And can it stop constant seizures? Can a drug developed just for an individual create change? And for him, this is an answer that we are looking and investigating. And currently, this will be a 2-year trial that ends in 2026. But they're seeing that there change that we are seeing with the ASO and initial findings. And so we are hopeful that we'll continue to see efficacy with ongoing dosing. And I just wanted to bring this to the cure community because this is an important aspect of the future of genetic testing is genetic interventions. And so, bringing forward the challenges of diagnostic odyssey through forums like your is very important because people often don't realize that there is such a challenge and that this is a specific community that really we really need to rally behind because it's commercial entities and other bigger entities are just not behind or readily the resources are not there. So it's very important to continue to bring forward attention. And I think that there is, and across the board, there's so much effort towards rare disease, and that's very important to keep at the forefront. So anyway, I just wanted to say thank you to Cure for the opportunity to discuss these kind of things that are happening currently. And I also wanted to thank a couple of people from n-Lorem Foundation who are also on the call, and who are integral in this trial implementation.
Thank you, Dr. Kim-McManus.